Welcome to your role in screening for cancer in primary care. My name is Della Hughes Carter. I'll be facilitating this talk. The continuum of cancer care is complex, and it begins with a risk assessment. As nurse practitioners, we offer not only risk assessment, but primary prevention, screening. Once we detect cancer, we refer to specialists for a proper diagnosis and treatment plan. But along the way, we help manage side effects of medications and the ill effects of cancer. We work in partnership and coordinate the care of many specialists. We help the patient through survivorship and, if necessary, through end-of-life care. Continuity of care is defined as how one patient experiences care over time, as coherent and linked, and is the result of good information flow, good interpersonal skills, and good coordination of care. And that's what we do as nurse practitioners. When we look for risk assessment, we must look at the environmental factors that a patient may have. Of course, we all know that tobacco is by far the leading cause of cancer. We also have alcoholism, obesity, and then certain exposures. And the one I want to point out here that you may not be as familiar with is the betel nut. This is a nut that is a stimulant. It's considered a recreational drug. It's originally found in the southern Asia area, but we're seeing it more in East Africa, Madagascar, those areas, West Indies. And there's little evidence to support the clinical use of this betel nut. It is really a recreational type stimulant. It has a very potent cholinergic activity. I'm starting to see this more and more in my population, but of course I work with a very diverse population. So just kind of be on the lookout for that. It's a question you might have for your patients. Selected nutritional factors, and we're going to talk about the treatment of HPV and hepatitis B and C, and how those can lead to cancer, and your suspicion for cancer should increase if your patients have had those diagnoses in the past. So we ask our patients what their occupational history is. And we do that for a number of reasons, not just for safety or getting familiar in generally speaking about about our patients, but also to kind of know, were they exposed to some type of carcinogen. And you can see from this graph here that we actually can identify certain occupations with certain types of cancers because of what patients have been exposed to. Because people spend so much time at work, potential carcinogens in their work environment have been studied pretty carefully. Some occupations, carcinogens have been identified because coworkers are exposed to the same substances, and then we get the similar kinds of cancers in higher frequencies. Something that I don't see on this graph, which I'm kind of surprised, is firemen, because I believe that firemen have a higher level of cancer than the general public. We know that from 9/11. We also know that patients that work at popcorn factories where they have artificial butter have a higher incidence of bladder cancer. So there's more to this list for sure, but it does give you some idea of what we're looking at. So we've provided for you a little checklist that may be helpful as you are working with your patients assessing for cancer. So we begin with breast cancer before the age of 60. Concerning, any of these that you get a positive or a yes answer to needs to increase your awareness concern for cancer. So breast cancer before the age of 60, or a triple negative disease. And what triple negative disease means
is that treatment options become more slim. So if so, the triple negative is if you have a protein, if you lack a protein such as an estrogen receptor or a progesterone receptor, which they're very useful for certain kind of hormone therapy treatments, that's off the table. The other problem is that if the other protein called the HER2 is not there, then cancer treatments that are targeted towards that specific um, receptor is not available. That means the only thing really that's left is treating the cancer with removing the mass and then chemotherapy. Triple negative breast cancers are highly resistant to chemotherapy. Less than 20% of women that have triple negative breast cancer who are treated with chemo drugs see any lasting results. Now, there is some new research that is coming down the pike that they think are going to be promising to help these women. But right now, if you have a triple negative type breast cancer, it's concerning for you and your patient. If your patient has colon, uterine, or pancreatic cancer before the age 50, that's very concerning. If you are seeing ovarian or fallopian tube type cancers or male patients with breast cancer of any age, those are most concerning. Um, Looking at trends in families where you may have multiple family members with the same type of cancer, such as colon or uterine, breast. Melanoma is actually one, even though that is on a rapid rise in our country. Certainly, if you have, going to number 5, Jewish ancestry in combination with a history of breast cancer, ovarian, or pancreatic cancer of any age, so that history is concerning. And then if you have polyps from having a lower GI and you notice more than 15 polyps, that is something that we must keep close eyes on. And then, of course, all the genetic mutations are something that will boost your concern and your keen diagnostic skills. So, how important is your job as a nurse practitioner in primary care? You are going to be the first line of defense for a lot of these patients. So, you'll find cancers from just routine screening. You'll find them because you're going to put together signs and symptoms of concerns, and we'll actually do a workup specifically for cancer, including your keen skills about their occupational health, um, their lifestyle choices. And then you may find cancers incidentally. But then, as soon as you find this cancer, you have to deliver the news to the patient or get them to a specialist right away and make sure that follow up happens. Sometimes those can be delayed, and this needs to be an urgent referral and then close the loop to make sure that it happens. And if the diagnosis does present itself, then you will be part of that team that coordinates the care for this patient. Uh, and we talked about those roles already. So the patient-provider relationship is critical because the patient may not want to be screened for some of these cancers. And so I think you have to have a frank discussion with them about the pros and cons of screening and what that may mean for them. In the next slide, we'll talk more in detail. We're going to look at the United States Preventative Services Task Force as well as the American Cancer Society because they have a lot of the screening practice guidelines published, and they're not always the same. So we're going to look at those two. There are others as well, but you'll have to decide between what practice guidelines you're going to work with your patient and probably tell your patients what each one of them recommends and come to a decision at that point. So this slide shows us the complexity of offering screening for certain cancers based on an older adult's comorbid condition. What this line is showing you is on the far left, where you begin with the older adult who has multiple comorbidities. You begin the screening. You have early detection of a certain type of cancer. Then you have treatment with some type of outcome. And to the far right, we have the outcome. Improved health-related quality of life and functional status is in question. The time from screening to outcome is decreased because of a patient's older age and maybe due to their comorbidities. So the U.S. Preventative Task Force is starting to do research on this exact concern. So let me read for you from their webpage. Mr. A has a history of falls, mild cognitive impairment, and has had recent heart attack shortly after his wife died. He's 72 years old and lives alone. His only daughter lives 100 miles away. Today he presents to you for his annual checkup, and you note that he has never had a colorectal cancer screening. Although he qualifies for screening by his age, his recent heart attack, history of falls, and cognitive impairment makes you wonder if this is in his best interest. Mrs. B is another patient. She's 74 years old with a congestive heart failure and Parkinson's disease. She uses a quad cane to ambulate, but is largely homebound due to her poor morbidity. Today she reminds you that today is time to order her mammogram, stating the last thing I want to do is die from breast cancer. So you can see in each of these scenarios an older patient with chronic illnesses and functional impairments who actually qualify for cancer screening from our published guidelines. But however, you wonder if screening is in the patient's best interest. Would Mr. A's heart disease and memory problems put him at high risk for complications from the colonoscopy? And could Mrs. B tolerate a lumpectomy and hormone therapy in light of her congestive heart failure and Parkinson's disease? How would her quality of life be affected if you ignored her preference for screening for breast cancer? These questions highlight the complexity of screening decisions in patients with functional impairment and chronic illnesses and need to be incorporated with information on quality of life and functioning into the screening decisions. Now that is right from the United States Preventative Services Task Force. And these are some of the research questions that they are posing, but you are going to come across these situations as a nurse practitioner. And at this point, it almost seems like an ethical dilemma to consider. And from my standpoint, if they qualify for the screening guidelines, I talk to them about that and I let them be an informed consumer and make the choice. So something to consider. So these two national organizations, they rate their level of evidence in different ways. So the United States Task Force has A, B, C, D, I, A being that it is recommended, and I meaning they have no information and just insufficient knowledge on the subject. The American Cancer Society has strong recommendations and then qualified recommendations. So I just want to pose that for you as we look at these guidelines. So as you can see, when we talk about lung cancer screening, the two organizations really are quite similar, not exact, but very similar. They do recommend a low-dose CT scan in healthy adults. The United States Task Force is 55 to age 80 with a 30-year PAC history of smoking and who have are still smoking or have quit within the last 15 years. They're saying that this is an annual screening, just like the American Cancer Society, but it can be discontinued once a person has not smoked for 15 years or has a health problem that would substantially limit their life expectancy or the ability or willingness to have curative lung surgery. So very similar for the American Cancer Society. If you take a minute to review these, please. So the U.S. Task Force says that for breast cancer screening, if you're between the age of 40 and 49 years old, this is decided individually with a grade C recommendation. But by the time you're age 50 to 74, they think you should have a screening mammogram every 2 years. That's a higher grade B. And then for those over 75, there is no opinion by the United States Task Force. Primary care providers should screen women who have family members with breast cancer, ovarian, tubal, or peritoneal cancer with mammogram or another type of tool to help to identify that, like an ultrasound or PET scan, CAT scan, those kinds of things. And then if you have a positive BRCA, you should have genetic counseling, and that's a grade D. So you can see the American Cancer Society is a little bit different because they're saying that if you're an average risk, so that means you don't have any family history of cancers such as breast, tubal, uterine, those kinds of things, ovarian, that you can start at 45 years old, and that's considered a strong recommendation. If you want to, between the age of 40 and 44, that comes in as just a qualified recommendation. But again, these are women without risk, high risk, these are average risk. If you're 45 to 54 years old, they think you can go to every they want you to every year, but after age 55, you can go every 2 years. And then you can continue that through until your life expectancy is less than 10 years or your overall health is really declined. They do not recommend clinical breast examinations for breast cancer screening among average risk patients, and that is a qualified recommendation. And here are the recommendations for colon cancer from the U.S. Task Force. 50 to 75 years and you're asymptomatic and not high risk, they recommend a screening with one of these tests here below. If you have the colonoscopy, I believe that's good for 10 years. But if you choose like the fecal occult blood testing, that's every year. If you do a multi-targeted stool DNA test, just know that if that comes back positive, you're going to need a colonoscopy anyway. So I kind of let my patients know that. And between the age 75 and 80 years, they want you to discuss with your provider. Although we know colon cancer is usually slow growing, the question is someone at age 80 want to go through the treatment if they do have it? Now, the American Cancer Society has very similar guidelines, but they put together a nice table. So I thought I would share that with you because it has the actual procedure followed by how often it is done. They don't mention, let's see, stool DNA test with high sensitivity for cancer here at the bottom. But again, if that's positive, they're going to need a colonoscopy. So when we compare the two when it comes to prostate cancer, the United States Task Force basically says that they are against the PSA screening for prostate cancer with a grade D recommendation, where the American Cancer Society gives you a little more room to negotiate. So men over age 50 with at least a 10-year life expectancy, they want you to talk to the patient about the risks of screening, the risks of false positives, the risks of treatment, and make a joint decision. African American men who have a father or brother with a prostate cancer before the age of 65 should really talk to their physician beginning at age 45 if they should have the test or not. I would substitute the word physician for primary care provider there in that definition. If they're tested, they should have the PSA blood test done and have that retested based upon the level. Screening is recommended mostly with the PSA with or without the digital rectal exam. Okay. Okay, so for prostate cancer, if you decide to do the screening, here are the guidelines for your levels. So, screening should be conducted every year for men whose PSA level is greater than 2.5. If you're less than 2.5, you can extend that interval. Once you reach the threshold of 4, then you probably want to recommend this patient to a urologist for a prostate biopsy. Um, for PSAs that are between 2.5 and 4, this becomes a judgment call, and you might need to look at other factors that are considered, like is the patient African American? Is there family history? Was the prostate hard or swollen? Um, so, probably if I have something that's abnormal, I'm referring to a urologist to get them on board early. So when I looked at the cervical cancer screening guidelines from the task force, the American Cancer Society, looked pretty similar. This one's a pretty easy to read slide where you have the age first, so less than 21, no screening. 21 to 29, you can have the cytology every 3 years. If you decide to go with the HPV testing, you want to start that after age 30, and that then extends your um, exam to every 5 years. And then they kind of say at 65, it's probably not unnecessary, especially if all your prior cervical swaps have been negative for any kind of abnormal cells. Now, this is very general guidelines. You should go to the website to get specifics because they do get much more detailed than I have listed here. Very similar to the American Cancer Society is the United States Task Force, and I've got them listed here with their grading levels. Um, Less than 21 years old, no screening, that's a grade D. Let's see, grade A is to not start the HPV till after age 30. That's a pretty strong recommendation. So, okay, take a look at these. So here's a nice little mnemonic for cancer workup. The word caution is used. So C is change in bowel or bladder habits. A is a sore that does not heal. U stands for unusual bleeding or discharge. T is for thickening or lump in the breast, testicles, or elsewhere. I, indigestion or difficulty swallowing. O, obvious changes in the size, color, shape, or thickness of a wart, mole, or mouth sore. And then N is nagging, cough, or hoarseness. So those are kind of a weak mnemonic, but maybe it'll help you a little bit with stimulating some thought. One thing I did want to mention is that we've heard over and over red flags for screening of back pain for fractures or malignancies. So there was a systemic review by Williams and Henschel in 2013, and what they found was that only the history of cancer was actually evaluated as a predictor in about 1 in 14 patients in primary care and 1 in 3 patients in the ED for those that had back pain. So again, looking at the red flags for back pain and does that mean cancer? And really the only corresponding finding was if they had a history of cancer already. I guess a sidebar to that is that red flags for a fracture of the lower back, you would have higher suspicion if they're older in age, prolonged corticosteroid use, severe trauma in the past or currently, in the presence of a contusion or abrasion, were really the only typical red flags associated with increased likelihood of a fracture. I know that's a sidebar, but getting back to the cancer part, lower back pain, really the corresponding complaint really was just a history of having uh, cancer with lower back pain. These make a little more sense to me. These are worrisome indications, other signs and symptoms. So, of course, unexplained weight loss, because the pathophysiology of cancer has to do with how much energy it takes to duplicate the cell. And so that eats up all your energy stores. So these patients lose weight. Persistent pain in bones or other areas that you can't explain why fatigue or tiredness, nausea and vomiting that persists. I know those are vague symptoms, but this is something that just you can't find an answer to, and it's getting chronic or worse. Low grade fevers or constant intermittent sweats, repeated unexplained infections. Again, pretty vague in all these areas, but as you start putting all the different pieces together, hopefully you'll be able to have a differential and a diagnostic plan. So just a reminder of the different stages that we have with cancer. Really, you need to go back to your pathophysiology and review cancer as well as your pharmacology. But here's some definitions for you. So now you know the importance of your risk assessment, intervening with primary prevention screening, detection, diagnosis. Now we move into your patient has cancer. You referred them to the appropriate specialists. And now what is your role as a nurse practitioner? And I know you know all the side effects of chemotherapy and the consequences of different uh, cancers. So what is your role now in helping to manage the fatigue, the nausea, the pain, the depression? Screening is such a big deal with cancer. If they're on opioids, how are you managing their constipation? So the next part of this will be what your role is as primary care provider in helping with some of the symptom management, working collaboratively with the different oncologists and cancer specialists with fevers and infections and neutropenia, things like that. So I hope you enjoyed this first part of your um, series here, and we start putting the pieces together for a really effective role as nurse practitioner in the management of cancer care.